As you know, rheumatoid arthritis is the most common chronic inflammatory polyarthritis. It occurs almost in about 0.5 to 0.75% of the population in India. It is an important cause of disability in middle age. In childhood, the cause of disability is predominantly birth injuries. In older age, it is due to stroke and osteoarthritis. If you see somebody in middle age and they are disabled, and rheumatoid arthritis is the number one cause. And as you all know, it is a disease of women, predominantly women. And because of that reason, it is also a social disease. If the woman of the family has rheumatoid arthritis, the entire home suffers. The advance in rheumatoid arthritis field in the last 2 decades has been enormous, but there's a huge knowledge gap between what is known in the literature and what has gone down or percolated to the physicians and also public. And this huge knowledge gap, there are multiple reasons. One is we don't have rheumatology in many of the teaching institutions, and many of the doctors graduate without ever being exposed to a rheumatologist. So, coming to the treatment plan, we have few central tenets in the management of rheumatoid arthritis, and for that matter, management of almost all autoimmune disorders. The central theme is inflammation multiplied by time is equal to damage, and the damage is permanent. So, this is the most important tenet, and the correct diagnosis leads to correct treatment. And there is something called window of opportunity, we shall discuss. And diagnosing early and treating early, and treat adequately and continue to treat. That's very important. And nowadays, we aim for remission or low disease activity, and many targets to achieve. There are many targets we shall discuss. And we should never forget, as a physicians, co-morbidities, which sometimes are very important in particularly treatment choice and the outcomes. So, disability in early rheumatoid arthritis is due to inflammation. If you have seen this joint, you can see the metacarpophalangeal joints swollen. A few PIP joints are swollen, and the stiffness and the pain is due to inflammation. It is potentially reversible. Compare this hand with this picture. Here also patient has pain, patient has got stiffness, but here the cause for the pain and disability is damage. You can see significant damage to the joints. You can see the ulnar deviation of the fingers, and this damage is irreversible. So, if we are able to identify patients before irreversible damage occurs, we can prevent the disease from progressing. So, we have the disease which starts and which can have a natural course is deterioration. By starting treatment at a later stage, at this level, we can make them better. The amount of deformities and disability will become less. If we start at a very early stage, within few months after beginning of the disease, the disabilities can be much lesser. And if we start much early, it's called very early rheumatoid arthritis. Within few months of the onset of the disease, we can almost bring them close to near normal, and patient can remain symptom free and deformity free over many years. Correct diagnosis leads to appropriate treatment. This is an important statement because due to various reasons, rheumatoid arthritis is not diagnosed many times. There is an undue reliance on rheumatoid factor test and anti-CCP test, and also ESR. So the patient sometimes can have aches and pains without a rheumatoid arthritis. They may have false positive rheumatoid factor, and if the diagnosis is wrong and your correct treatment for rheumatoid arthritis will not help. So the treatment for rheumatoid arthritis, though it may be perfect treatment for rheumatoid arthritis, but the diagnosis is wrong, everything goes wrong. So RA is always a polyarticular disease. The monoarticular rheumatoid, oligoarticular rheumatoids do occur, they are exceptions, they are for the specialist. For 95% of the time, rheumatoid arthritis is polyarticular. Polyarticular means at least minimum 5 joints are affected, and it is symmetrical, generally affects both the side of the body. And you need to document arthritis. Arthralgias are extremely common. Every viral fever causes joint pains. But joint swelling we should document. If there is a swelling in the joint, if there is a erythema, if there is a pain on movement in both the directions, then we would call it as arthritis. And if there is an arthritis, then you can start thinking about rheumatoid arthritis. And also be aware of false positive rheumatoid factor test. Rheumatoid factor test can be positive in many infections, tuberculosis, Hansen's, many viral disease, including COVID. Rheumatoid factor test can be positive. 5% of the normal population can have rheumatoid factor positivity at a moderate to mild titers. So, higher the titer, it is more important. And high titer rheumatoid factor positivity, along with a clinically demonstrable rheumatoid arthritis, increases the likelihood of rheumatoid arthritis. So, there are a lot of things you should think about and do before you make a diagnosis of rheumatoid arthritis. And always consider fibromyalgia and other connective tissue diseases in the differential diagnosis, because fibromyalgia is very common. It also occurs in women, and it can cause subjective rather than objective swelling. And we need to differentiate between inflammatory and non-inflammatory arthritis. The classical example is non-inflammatory arthritis is osteoarthritis, inflammatory arthritis, rheumatoid arthritis, and other connective tissue disease. And we should not be missing connective tissue disease, because many connective tissue diseases also have rheumatoid factor positivity. They can present with polyarthritis. So if you don't pick up other clues for connective tissue disease like lupus, we may mistakenly treat the patient as rheumatoid arthritis. So I always insist on look at the company arthritis keeps. We call it as an arthritis plus concept. Arthritis plus something. Arthritis plus significant anemia, unlikely to be rheumatoid, can be lupus. Arthritis plus significant skin disease, it can be psoriasis or psoriatic arthritis. So this is an important slide to differentiate arthritis and arthralgia. Come out the diseases like fibromyalgia, hypothyroidism, malignancies, osteomalacia, even undetected diabetes, peripheral neuropathies, all can present with arthralgias. Post-infective arthralgias are also very common. So these are all arthralgias, and if you do ESR, it can be high sometimes. And if a rheumatoid factor is false positive or low titer positive, you may mistake this patient as rheumatoid arthritis and put them on treatment which are potentially toxic. If you have the right disease, any treatment is a right treatment. But if your diagnosis is wrong, even the perfect treatment will go in the wrong direction. And fibromyalgia, as I told you, is a very common mimic because it occurs in the same age group, and patient complains of lot of swelling, but we may not be able to identify the swelling. Morning stiffness is very common, but here inflammatory markers are normal, and antibodies are generally normal, and they have multiple somatic symptoms like headache, irritable bowel syndrome, IB, sleep disturbances, depression, etc. And many times it is diagnosed as seronegative rheumatoid arthritis. So we need to be very conscious of this disease, because this is one disease which has too many symptoms, and they also have chronic widespread pain. They'll have pain in the joints also, but also they may have pain elsewhere, away from the joints as well. So this is the picture which is there in the upper half is osteoarthritis. If you look at the pattern is distal interphalangeal joint, proximal interphalangeal joint, and if you look carefully, first CMC is also affected. This combination is more likely to occur in osteoarthritis. And also look at the swelling. Swelling is bony. It looks little bony swelling compared to the picture which is down, which has got post-inflammatory hyperpigmentation in the metacarpophalangeal joints, and the swelling is little fusiform and subtle. So this is likely to be rheumatoid, and the above one is definitely osteoarthritis. And I alluded to arthritis plus concept. If you have an arthritis plus nail changes, like a arthritis plus a dirty looking nail, it can be psoriasis. Arthritis plus what we call as a dactylitis, uniform swelling of a digit is called dactylitis, which it is not arthritis. This toe, third toe, has dactylitis. If your patient has got a swelling like this, think away from rheumatoid arthritis, whether it is psoriatic arthritis, whether it can be ankylosing spondylitis, or it can be even tuberculosis if there is only one joint. So this patient also has psoriasis. So arthritis plus systemic disease, think of lupus. Arthritis plus significant diarrhea, bloody diarrhea, consider inflammatory bowel disease related arthritis. And arthritis plus either uveitis, scleritis, dry eyes. You can have it in almost all connective tissue diseases, including rheumatoid arthritis. So, arthritis plus concept is always important to differentiate arthritis and rheumatoid, other connective tissue disease, because other connective tissue disease also can have rheumatoid factor positivity. These are the red flags. If you have a patient with rheumatoid like arthritis, but he has lost a lot of weight, has very high grade fever, the patient looks very unwell, and the patient is elderly, because we have a differential diagnosis: polymyalgia rheumatica, giant cell arthritis, even malignancy related arthritis. So these patients may not have rheumatoid. Significant muscle weakness, patients may have dermatomyositis and RA like arthritis. Rashes, neurological symptoms, significant anemia. Anemia of chronic disease can occur in rheumatoid, but an anemia of 4, 5 will never occur in rheumatoid. So we need to think about a lupus or other connective tissue disease. And significant bowel and multi-system involvement takes the diagnosis away from rheumatoid arthritis, though rheumatoid also can be multi-system, but that occurs in a little later disease. It can affect any organ in the body, but it doesn't occur in the beginning. So these are the red flag diseases: lupus, scleroderma, dermatomyositis, vasculitis, Behçet. Infective endocarditis and sepsis can mimic rheumatoid arthritis, because rheumatoid factor can be positive. They can have polyarthritis, but they also have a lot of skin lesions and even proteinuria. Hepatitis B prodrome, which was very common earlier days, nowadays it has become uncommon. It can also have RA like polyarthritis, and they can have rheumatoid factor positivity. So always look for arthritis plus symptoms so that your differential diagnosis widens. So coming to diagnosis based on polyarthritis, presence of serological tests like anti-CCP or rheumatoid factor in high titer, and the duration also is important. If somebody has a polyarthritis of few weeks duration, it can be viral, but if it is of 6 months duration, it's more likely to be rheumatoid or inflammatory arthritis. And presence of high ESR or CRP also is supportive. So anti-CCP is a much more specific test, It occurs early in rheumatoid arthritis, and it is much more specific. It predicts rheumatoid arthritis if it is detected in an early stage, and higher the titer, more important it is. And coming to rheumatoid factor, it is rheumatoid factor and not rheumatoid arthritis factor, like most labs call it as a RA factor. It is not RA factor because it can be positive in many rheumatic diseases and also non-rheumatological diseases. It is useful for diagnosis. It higher the titer, more important it is. But once it is diagnosed, it is not useful to repeat it. If the titer has come from say 200 to 100, it doesn't mean that patient is not better. And if it disappears, doesn't mean that patient's rheumatoid arthritis is gone. No. So there are patients who have rheumatoid factor disappearing but having aggressive arthritis. And also there are patients who have persistent rheumatoid arthritis have gone into a drug-induced remission. So never repeat rheumatoid factor or anti-CCP after using it for diagnosis. They are only useful for diagnosis, but they are not useful for prognosis or assessing treatment response. And we also discussed about window of opportunity, and we need to diagnose early, and treat adequately, and treat long enough. So this is one of few couple of important tenets. Why we should worry about window of opportunity is, we know that rheumatoid arthritis is an autoimmune disease. The immune inflammation matures over time. In a very early stage, it is amenable to treatment and disease modification. And also early stages, permanent damage has not happened. We look at the pictures here, progressively the joints have become more and more deformed. So once deformed, whichever medicine you give, even if you give the best medicine, the patients will feel better because inflammation still comes down. Extra-articular inflammation also comes down and prevented, but they can never be normal because they have already lost the boat and the deformities have already set in. It is like treating a patient at a very late stage is similar to trying to brush regularly after you have developed severe caries. The brushing now very well will prevent a new carie, but existing carie will continue to progress and you may require more dental procedures. And there are good studies to say that very early aggressive treatment, when the disease just starts, few joints have come, and within few weeks you have identified. And if aggressively treated, you can even prevent development of a classical rheumatoid or textbook rheumatoid arthritis will never develop. And other tenets are remission is the goal. Remission means no disease activity, no swelling in the joints, no stiffness, no tenderness, and ESR CRP should be normal. If remission is difficult to achieve, sometimes it is difficult because we don't see patients early enough, and later the disease comes, it becomes more refractory. So there's a definition called low disease activity. We accept few joints here and there, and we accept mildly elevated ESR CRP. If functionally the patient is better, that is an acceptable outcome. And we need to achieve a remission when possible. And achieving a remission is easy. If we give good enough dose of steroid, most patients will go into remission. Sustaining the remission is difficult. And there is always a target, like we have a target for blood pressure. Blood pressure target is you have to keep the blood pressure below 140/90 or 135/85. That is an acceptable target. We aim for it and achieve it, and outcomes are better. Like HbA1c, you want to have a target HbA1c of less than say 6.5 or 7. We know that cardiovascular outcome, diabetic outcomes are much better in these patients. So having a target is always useful. We have a composite target which we shall discuss. So we have multiple targets which includes joint counts, ESR, and also patient assessment about the disease and the doctor assessment. So we are able to achieve a clinical remission, is still achievable. These are the tools which are used. Imaging or serological remission is much more tough to have, and imaging remission means there is no synovitis by ultrasound or MRI. Ultrasound and MRI are much sensitive tools to pick up early or persistent inflammation, even when your hands can sometimes miss it. And immunological remission, that means your rheumatoid factor, CCP, everything is gone. So seroconversion should be documented. This is called deep remission, deep sustained remission. It is almost a cure. Still a pipe dream, but sometimes we can document it. And we should measure progress, because unless we measure progress, we don't know whether our patients are really doing well or not. Because after the initial visit, most of the patients start feeling little better. A little better doesn't mean that they are really doing well. So we need to assess. It's a complex disease, not easy to measure like HbA1c, blood pressure, or LDL cholesterol. So we always have a composite index which includes multiple parameters like swollen joint, tender joint, CRPs, and patient's global assessment, etc. These are the tools which I will not bore you with. They are the core sets which we use in clinical trials and also in a clinic to assess the improvement and to document remission. There are remission scores like a DAS28. If you are using this tool, a 2.6 and below are called remission, and there are other tools, the different numbers are there. So if the target is to achieve a remission, and if not remission, low disease activity, for which also there is a definition. So there is a remission definition, and also there is a low disease activity definition. So we always try to achieve this in the clinic, and if you are able to achieve the long-term outcome, the textbook deformities you all are familiar with, all the deformities, swan neck deformities, botaneous deformities, ulnar deviations, all will not happen. So it is nowadays in a patient whom we have diagnosed in the recent past, it's extremely difficult to see a deformity, and many of the new trainees have not seen a classical deformed rheumatoid arthritis. That is the advance in rheumatology in the last 2 decades. So goals we had already discussed, remission, and we also try to prevent radiological damage, because one of the typical features of rheumatoid arthritis is joint erosion. So if early control of the disease prevents joint erosion, and of course every treatment requires an improvement in functional ability for it to be called as a successful treatment. The patient joints are all normal, but if the patient is still not able to walk, our treatment is not considered a great success. So functional improvement should be documented. So these are the treatment principles. By this time you would know where I'm going to come, because early correct diagnosis will lead to prompt correct treatment, and earlier we diagnose, we start therapy early, and that is not enough. We can start somebody on say 7.5 milligram of methotrexate. That is not enough. We need to periodically assess and escalate the dose to the maximum allowed dose or maximum tolerated dose. For example, methotrexate can be escalated every month from say 10 milligram or 15 milligram to a maximum of 25 milligram if patient tolerates it. And these are the drugs which have potential side effects. They are not simple angel drugs. So we need to constantly monitor them every month initially. Then every 3 to 4 months, we monitor their liver function test, blood counts, creatinine, etc. Another important principle is, till today, methotrexate is the anchor drug. And I need to tell you that methotrexate in this context is not an anti-cancer drug. Most of the doctors think that methotrexate is an anti-cancer drug, rightly so, because that's what we read in our pharmacology books. but the dose there is totally different. High dose methotrexate is an oncology drug. Low dose methotrexate is a totally a different animal, and it is an immunomodulator or anti-arthritis drug or disease modifying drug. When methotrexate is not indicated, like patients with liver disease, patients with significant cytopenias, or patients who don't tolerate methotrexate, leflunomide and sulfasalazine are used as alternate anchor drugs. We can use these 3-4 drugs in various combinations. Sometimes we can use a small dose of steroids on a very shortest period of time to manage a flare or manage the disease until the disease modifying drugs start working, which will take about a month or two. The next step is to give biologicals or targeted synthetic DMARDs. The methotrexate and other drugs are called conventional synthetic DMARDs because they are all non-specific immunomodulator drugs. Many drugs are discovered for many other purposes. We have repurposed these drugs for as an immunomodulator in rheumatology. For example, methotrexate was discovered to be a cancer drug and used first by dermatologists for psoriasis, and we have borrowed this drug. Whereas leflunomide and sulfasalazine are designer drugs designed for rheumatoid arthritis. In contrast, targeted synthetic DMARDs are, we know the immune derangement. We know that certain cytokines have a problem. So we target the cytokines. We know that TNF is in excess in rheumatoid arthritis, and TNF plays a significant immune aggravating role in rheumatoid arthritis. We try to block. So that is a specific targeted biological therapy. When we use a targeted tablet form medicine, it's called targeted synthetic disease modifying anti-rheumatic drugs. They are the latest drugs. Conventional disease modifying drug, methotrexate, the maximum dose is 25, leflunomide is 20 milligram, sulfasalazine is between 2 to 3 grams per day, hydroxychloroquine 200 to 400 milligram per day, tacrolimus sometimes we use 1 to 3 milligram, ecuratimod up to 50 milligram per day, and rarely we use other drugs like penicillamine nowadays. And these are the blood tests which are required to be done in all patients. We should do a blood count, liver function, creatinine. And people who require liver active drugs like methotrexate, leflunomide, and azathioprine, we should do probably hepatitis B and C. And a chest X-ray always useful as a baseline because somebody develops a chest symptoms. And we should always have some baseline X-rays. Initially, we repeat blood counts and SGOT, SGPT every 2 to 4 weeks until the dose is stable, then every 3 to 4 months. And creatinine should be repeated minimum every 6 months because sudden increase in creatinine can lead to accumulation of some of the drugs and lead to hematological side effects. And with methotrexate, other drug being effective, we should we need more drugs? Yes, because in spite of being aggressive, in spite of doing everything in the clinic, 20 to 30% of the patients don't enter into remission. Because some patients progress despite treatment, and if a window of opportunity is lost, if you are not able to treat the patient early, we may not be able to achieve a good control. And immune system also is clever. When we are blocking certain pathways in the immune system to control the disease, it can take a detour and use another redundant system to bring back the inflammation. Unless we know what is the root cause and remove the root cause, there is always a chance that immune system will find a way out, escape route, and start attacking the joints again. So that is the biggest problem in autoimmune diseases, because still we are not able to really go to a cause and eliminate. Some of the causes are not eliminatable also. If COVID has started an autoimmune disease, how are you going to go back in time and remove COVID from the body? It's extremely difficult. And if some patients who are DMARD intolerant, if they don't tolerate DMARDs, certain special situations like pregnancy, if the disease is very active and the patient doesn't respond to sulfasalazine, which is a safe drug in pregnancy, then we may have to use biologicals. So there is a need and a role for biologicals, which helps to achieve a control in a patients who are not able to be controlled with conventional synthetic DMARDs. This slide gives you a bird's eye view of the immune abnormality in rheumatoid arthritis. You will find that almost all the players of the immune system are playing some role. Dendritic cells, which are presenting to T activated, which in turn activates the B cell, and B cells again produce more autoantibodies and again stimulates the T cells. We can block that with rituximab, and macrophage gets activated and they produce a lot of cytokines including TNF alpha and IL-1 and IL-6, which can be blocked by drugs. So multiple pathways play a role, and sometimes we don't know which is the key player in that particular patient. That is the reason the choice of drug is only trial and error. Sometimes we use rituximab, patient doesn't respond, then we have to use the other drug. Still, we don't have a clear-cut 100% foolproof markers to say that, okay, this patient will respond to this particular drug. So at this moment, the choice of the drug is an intelligent guess. With the available clues, we can make a guess that, okay, this drug is likely to help. But sometimes it is trial and error, and if the patient doesn't respond, we may have to switch to a different drug. What are the biologicals available? TNF inhibitors. TNF is tumor necrosis alpha, which is a key cytokine which drives inflammation in autoimmune disease, rheumatoid arthritis, ankylosing spondylitis, even sometimes in sepsis. TNF plays an important role. TNF is also very important in tuberculosis containment. To form a granuloma, TNF is very important. So the drugs available to treat target TNF is etanercept, infliximab, adalimumab, and golimumab. They are all available in our country. B cell depleters are rituximab. We have anti-IL-6, tocilizumab, and T cell stimulation inhibition, abatacept. These are the drugs which used to be available in our country. Abatacept is no more available in our country now. And the new kids in the block are what we call as a targeted synthetic DMARDs, which target many cytokines effect. See, if you know how cytokines work, all the cells have some receptors for cytokines. If this is a cell, this is a receptor. Cytokines float and join the receptor. Once the cytokine and receptor joins, inside the cell, lot of changes happen in the phosphorylation. So the receptors like JAK receptor, they get phosphorylated, and that results in activation of some of the proteins. That proteins get into the cell nucleus and they stimulate the DNA to produce cytokines and other inflammatory markers. So this targeted synthetic DMARDs block the intracellular pathway. So by blocking the intracellular pathway, they can reduce the problems of many cytokines from different groups. So they are broad spectrum immunomodulators. They are called small molecules because they have the kind of power of biologicals, therapeutic potential of biologicals, but they are tablets. That's why they are called small molecules. And biologicals are big molecules. The size is between an ant and elephant. So that is the size difference between a tablet from tofacitinib and a biological like infliximab. And they inhibit JAK kinase pathways. And side effect profile is generally acceptable, but there is a definite increase in risk of infections. Herpes zoster is 2-3% of the population of the people who take this medicine can have herpes zoster. And we need to avoid this drug in people with cardiovascular risk like diabetes, hypertension, obese, because there is a slight increase in risk of cardiovascular mortality and DVTs. So these drugs, though effective, can be potentially problematic. We have to choose the patient very well. And monitoring schedule is very similar to methotrexate, blood counts, lip. One more thing which you need to look at in this is lipids in addition to liver function test and creatinine, because tofacitinib can slightly increase the lipid profile. If they already have a cardiovascular risk pattern, this may cause a problem, so may have to address that. And they are very effective, biologicals and JAK inhibitors, but not everybody respond. So we need to do a little bit of trial and error. So one fails, we will go to the other. They are generally expensive, though the tofacitinib has become cheaper and affordable with the cost between 2,000 rupees a month. And there is definitely infection risk. We need to do tuberculosis screen, that is latent tuberculosis screen. We should also do hepatitis B, C and HIV to prevent this virus from getting reactivated. And there is also a theoretical risk of future malignancy, though the trials of late up to 15-20 years have shown us that there is no major increase in cancer risk except for non-melanoma skin cancer, which is a treatable type of cancer. So data has been reassuring so far. And when it comes to comorbidities, which as a physician we should never forget. Rheumatoid arthritis patient died 10 years earlier. And the rheumatoid arthritis sometimes don't kill, but it is the comorbidities which kill. So we need to always screen for cardiovascular risk. So we should screen for diabetes, lipids and metabolic syndrome. And metabolic syndrome is also very important because many of them have a fatty liver. When we give drugs which can have a work action on liver, it can be problematic. So fatty liver is also number one cause for hepatic failure nowadays. Methotrexate plus fatty liver can be a recipe for liver cirrhosis. And we should advise the patient to stop smoking and moderate alcohol. Encourage physical activity because physical activity is anti-inflammatory and also reduces sarcopenia, reduces the fall risk because patients with rheumatoid tend to have sarcopenia and increased risk of fall. And they also have a higher risk of osteoporosis. So we need to screen them for osteoporosis and treat if it is present, and also consider giving them flu vaccine and pneumococcal vaccine. So as I have told you, this is an autoimmune disease. It starts with subclinical autoimmunity and slowly progress to clinical autoimmunity. And can we predict and prevent rheumatoid arthritis? There is no 100% way of totally preventing rheumatoid arthritis, but from what we know from literature, there are few things. If a patient comes to us with, I have my knowledge, we can give them reasonable recommendations. Like we can ask them to stop smoking because smoking is associated with development of rheumatoid and also worsen the progression, and also smoking patients don't respond well to rheumatoid arthritis treatment. And reduce the exposure to inhaled silica, dust and occupational risk, like even the vehicle exhaust. If you stay close to the highway and where a lot of vehicles ply, that is itself can increase the risk of rheumatoid arthritis. So you can try to probably live in an area which is less polluted. Maintain a healthy weight because obesity is linked to rheumatoid arthritis. So probably preventing obesity can have a protective role. Physical activity can be protective. Dental activity, we all know that dental hygiene, periodontitis is a risk factor. So maintaining a good dental hygiene, doing preventive dental health checkup may help to delay or prevent the onset of rheumatoid. And breastfeeding, if somebody is a childbearing age group, if they breastfeed, longer they breastfeed, the chance that they develop rheumatoid arthritis is low. And avoid processed food, high salt diets, avoid sugar. These are all supposed to promote inflammation. Eat anti-inflammatory diet, predominantly plant-based diet, high fiber diet is definitely useful to keep the gut bacteria balanced. And gut bacteria balance means ILs T regulatory type of lymphocytes dominate compared to autoimmune phenotype lymphocytes. And I can't recommend alcohol intake, but a little bit of alcohol intake can be protective. Having enough omega 3 fatty acids and fish intake can be protective. And avoiding sodas and sweetened drinks can be protective. And low vitamin D can be an aggravating factor. So having adequate vitamin D can be also protective. So in RA management, we are able to relieve the symptoms. We are able to prevent the joint damage provided we treat them early. We can definitely make them functional. Many of our patients are still working as teachers, doctors, engineers after 20 years of diagnosis. We are able to induce remission with drugs. Drug-free remission and prediction and prevention are still in the early stages. We are getting there, but still not reliably done. So, ladies and gentlemen, this is my last slide. We have discussed about the need for correct and early diagnosis. Correct diagnosis is very important because without correct diagnosis, nothing of what we have learned will be useful. Because your diagnosis is wrong, you will go totally in the wrong direction. And always, if you have a diagnosis, refer to a rheumatologist, get your diagnosis confirmed, let them give you a formula, then you can manage the patient and you can only refer them back when there is a complication or a problem. And window of opportunity is narrow. First 3 months or 6 months is very crucial in making a huge difference to the patient. So wait and watch policy is not good in rheumatoid arthritis. And prompt and adequate DMARDs, we need to achieve low disease activity or remission, and we need to continue to use the drugs to sustain the remission, so that once you stop the drug, if disease comes back, we are back to square one. We can use steroids, but very judiciously, shortest period of time. Long-term steroid should not be used. And if you have noticed, I never discussed about painkillers, NSAIDs, and all our DMARDs which I had discussed are safer than non-steroidal anti-inflammatory drugs and regular steroids. All our biologicals, methotrexate, scary sounding drugs, they are all very safe compared to your ibuprofen, naproxen, etoricoxib, and daily steroids. When we are worried rightly about side effects of the drugs, we also should think about the side effects of the disease. Uncontrolled disease can cause deformities, social problems, and also increases the mortality, cardiovascular mortality by at least significant percent, reduces the lifespan by 10 to 15 years. And apart from conventional synthetic disease modifying drugs, biologicals and new synthetic targeted synthetic DMARDs are very useful tools to achieve remission in patients who are difficult to control with the conventional disease modifying drugs. I think with this, I will stop. Thank you very much for the patient hearing.